My name is Dr. David Standard. I'm the chairman of the Department of Neurology at the University of Alabama at Birmingham, and I'm also director of the Alabama Udall Center for Parkinson's Research at UAB. And I'm glad you're able to join us today to hear a little bit of an update on Parkinson's research, find out what's new in the field and what the Udall Center is doing. So I'm glad to see we have a great crowd out there today. Just a few things about the plan here. So we have 3 speakers today. We're going to try and each speak for about 10 or 15 minutes and then leave time at the end for questions. To ask a question, if you look at the bottom of your screen, there's a box that says Q&A. You can type your question in there, and then we will work through them. Katie Fugler will pull them together and organize the questions at the end. You can type the question in anytime, so whenever you think of it, go ahead and put it in the box, and then we'll get to all the questions at the end of the presentation. So thank you again for joining us, and I'm sure all of you are interested to hear what's been going on in Parkinson's research. The news has been dominated so much by so many other things recently, COVID-19 and the other issues in our country at the moment, but the background, the work on Parkinson's goes on. Our mission here is to find better treatments for Parkinson's disease, and ultimately we hope to cure this problem and put ourselves out of business. That's our goal. So we're going to tell you a little bit about where we are and what we've learned recently. So this is sponsored by the Parkinson Association of Alabama, our partner, and the Alabama Udall Center, which is funded by the National Institutes of Health. So our program today has 3 parts. I'm going to speak first, and I'm going to talk about what's new in Parkinson's disease research. So I'm going to just give you some highlights in 10 or 15 minutes on some new things that are going on in the research field and things you'd probably like to be aware of. Following that, Dr. Amara is going to talk about early and prodromal Parkinson's disease. This is an area of a lot of interest both to patients affected by Parkinson's and to the research field. And she'll give you a little bit of an update on what's new and what's important in that area. And then Dr. Yakubian is going to talk specifically about what the Udall Center has been doing and our research activities and how you might be able to be involved in those research activities. And then lastly, as I said, we'll take your questions and answers. So please do go ahead and type those questions into the Q&A box at the bottom of the screen as we go, and we'll get to those at the end. All right, so what's new in Parkinson's disease research? The answer to that is a lot is new in Parkinson's disease research, and I could easily fill the whole hour talking about this. But let me hit just a few highlights for you to give you a sense of why we're so excited about this field and why it's changing so fast. So here's 3 big questions about Parkinson's disease. What causes Parkinson's? I think every person I meet who has Parkinson's asks me this. Why do I have this? We have not solved this question entirely yet, but I think we're learning a lot more about it, and I'll tell you a few things about that. How can you treat the symptoms? Are there ways to treat the symptoms? Absolutely, there are ways to treat the symptoms. I usually say that for most people who come to our clinic, we find a way to improve their treatment or help their symptoms. There are a lot of new medicines on the market just in the last year, and we'll touch on those to give you a sense of how quickly that area is changing as well. And then lastly, what about slowing or preventing disease progression? Can we stop this disease? Can we slow its progress over time? This is what everyone would like to accomplish. And where are we with this kind of research, and where are we going? So I'll give you a little sense of that as well. All right, so in terms of what causes Parkinson's, I wanted to make the point that genetics is still among the most powerful drivers of disease that we know. And the ability to study the human genome is getting better and better and better every day. The first human genome was sequenced probably about 15 years ago now. It took 10 years to do it, and it cost about $11 billion. We can now sequence somebody's genome in an afternoon for probably about $1,000. So it's really become something that is accessible. Not used yet in routine medical practice, but we are using it diagnostically in other disorders. And so we can really start to read the whole genetic code. And when we do that, we find a lot. What we find, and you can see in this graph over on the right, every one of those red dots is a gene that has some relationship to causing Parkinson's disease. There are more than 70 of these, so there's a lot of them. Each individual one doesn't seem to do all that much by itself usually, but depending on what combination of them you have in an individual, this probably has a big role in determining the risk of Parkinson's disease. And we're digging deeper into understanding each one of these 70 genes, how they play off against each other, and how that can help us to understand the Parkinson's that occurs in a particular person. Another thing about this is that it lets you start to think about personalized medicine in Parkinson's disease. So are there treatments, should treatments be based on the cause? If we understand more about the genetics, should people with particular genetic combinations get treatments that are different than people with other genetic combinations? Is that part of the reason we've had so much trouble finding a treatment for Parkinson's? Is we've been approaching it as we're looking for a treatment for one condition, when in fact there's all these genes, and maybe it's not one condition, maybe it's better thought of as a family of different conditions, and you need to customize this, the era of personalized medicine that you hear a lot about. In terms of the strong signals are a protein called alpha-synuclein. You'll hear a lot about that today. And then a gene called LRRK2 or LRRK2. And then lastly, one that goes by GBA. These are the three sort of strongest signals for genes that cause Parkinson's. Now, when I talk about genetics, I always get the question of, well, if my father has Parkinson's, am I going to get it too? And in most cases, the answer is your chances are no greater than anyone else. If you have one person in your family affected by Parkinson's, the chance that it will run strongly in your family is low. Now, if you have 7 or 8 people in your family affected by Parkinson's, that's a different story. But for the average person, the inheritance from one generation to the other to the next is not that strong. But these genetic signals are a clue, and this is a very powerful area of research, and I think you'll want to keep your eye on this. Another area that's very powerful is the microbiome. What's the microbiome? These are all the organisms that live on us and in us and with us, all the trillions and countless numbers of bacteria that are on our skin, in our gut, that live with us every day. They're a normal part of our life, but they may have a role in causing disease at times as well. Some very recent work from Zach Wallen and Dr. Pyami here at UAB have done a very detailed study of the organisms that are in the gut. Some of you, if you are a part of the UAB Parkinson's Clinic, may have contributed to this work. And they show that there are specific bacteria that are over-accumulated in Parkinson's. And many of these bacteria are not very nice bacteria. They're bacteria that we associate with disease and inflammation. So it's a little bit of a chicken and the egg question. Did those bacteria cause the Parkinson's, or did they arrive because the person had Parkinson's? That's something we can't answer yet. But this connection between the organisms in the gut and the condition in the brain is an intriguing one. And I think a lot of scientists are very interested in understanding more about this. How can organisms that are really part of our daily life, they live with us every day, how are they influencing what goes on in our brain, the state of inflammation in the body? And so these are critical questions as well. What about environmental factors? We talk a lot about genetics, we talk about the microbiome, but the third big player here is the environment. Are there things in the environment that can contribute to the risk of Parkinson's disease? I think most scientists would agree that there are environmental factors. I don't think we've identified all of them, but some of them that are well known. Pesticide exposure. So if you are an agricultural worker or live in an area with very high use of pesticides, Southern California, where they're used very intensively, there is an increased risk of Parkinson's associated with it. And certain pesticides seem to be more of a bad actor than others. Things like traumatic brain injury, having a head injury earlier in life does increase your risk for Parkinson's. What about protective things? Well, strangely, smoking seems to protect you against Parkinson's. Now, I don't recommend smoking. It causes lung cancer, and that's not a good thing. But people who smoke tend to have a lower incidence of Parkinson's. Now, why is that? Some work suggests it's the nicotine in the cigarettes. Other work suggests it's some other chemical, but there is a connection there. Caffeine at low doses, 1 or 2 cups a day, seems to have some beneficial effect. And exercise may also have a benefit in Parkinson's as well. So these are some things that we know about, but there's a whole world of environmental exposures that we don't really understand. And I think this is a critical area where we need to actually do some specific research on particular environmental toxins to try to understand their relationship to Parkinson's. And this is one reason I'm very happy to tell you that we have a new scientist joining our group, Dr. Brianna DiMiranda. Is coming from the University of Pittsburgh, and she specifically studies the role of environmental toxins in causing Parkinson's disease. The toxin she studies actually is something called trichloroethylene. This is a very common toxic substance that's found in many Superfund sites in Alabama. It was used as an industrial solvent for many years. And so there's quite a bit of it around in our state. And I think understanding more of that and its potential relationship to Parkinson's is really going to be important. So we're looking forward to having Dr. DiMiranda work with us on that. What about new treatments? Are there new treatments for Parkinson's? Actually, there were a lot. In fact, I made this list the other day, and I was surprised how many new treatments there are, just probably in the last year and a half or so. I'm not going to go through all the details of these different treatments, but they're really tackling different aspects of Parkinson's disease. It's a drug called istradefylline. This is a drug that has been under development for probably 20 years, but it works on a particular receptor called A2A, and it's a treatment for wearing off symptoms. There's a drug called safinamide, which is a monoamine oxidase inhibitor, has some relationship to drugs like rasagiline, but has some different properties as well. Then there's some new ways of getting levodopa into the system. There's an inhaled levodopa called Inbrija, which is useful for wearing off. A brand new drug that was just approved within the last 2 or 3 weeks, sublingual apomorphine. So apomorphine is a dopamine drug that's been around for a long time, but until now we had to inject it, which is inconvenient. This is a strip you can put under your tongue, acts to relieve wearing off symptoms. And this something we studied in research here at UAB and is now on the market. And then lastly is a drug called opicapone, which is similar in some ways to Comtan, or one of the ingredients in Stalevo, but it's a COMT inhibitor. This is a once-a-day version of this. So all of these have just hit the market, and honestly, we've only begun to use these in our clinical practice and to try and learn how they fit in with the other drugs that we already have. And this will take some time to really understand what the relationship of these is to the treatments that already exist today. But it's amazing to see so many new avenues for treatment emerging so quickly. Another big area are technological advances. So deep brain stimulation, very important technique for treating Parkinson's disease, has been around for more than 20 years. But there's a new technologic advance here called directional deep brain stimulation, where you can focus the electrical field in a particular direction of the brain. This gives you a lot more ability to adjust and refine this treatment. And there are also several new companies. For many years, only Medtronic made deep brain stimulators for patient use. Now there are at least 3 different companies, and they're making different equipment and really innovating in the field. And I think it's a really exciting time for deep brain stimulation. Another technique called focused ultrasound has received approval for treating tremor. This is a technique where you can essentially perform surgery on the brain without opening the skull. You use a very high-powered ultrasound machine to form a hole, to burn a hole in the brain right in the right spot, and can relieve symptoms of tremor. And it is FDA approved for treatment of tremor. Treating other symptoms in Parkinson's, it's being studied, not yet approved for that, but that is another exciting new technology. We don't have a focused ultrasound system here in Birmingham yet, but people are looking into this. What about disease-modifying therapies? This is the place that we would all like to go. This is the goal of almost all our research. How can we slow or stop the progress of Parkinson's? And I've talked to many patients with Parkinson's over the years, and often they're concerned about the symptoms they have today, but their real concerns are about what's coming in the future. And can we slow this down? Can we prevent this disease from progressing? And so I think there are 3 big areas that people are looking at in terms of disease-modifying therapy. One is focused on this protein synuclein, alpha-synuclein. And this protein clearly builds up in the brain in Parkinson's. There's too much of it. It's misfolded. It's in abnormal forms, and it triggers damage. So how could you get rid of the synuclein? One big way to approach this is infusions, antibody infusions that you would get. The studies are using once a month infusions that might remove the synuclein from the brain. There's several big companies that are studying this. One of them has reported out some preliminary results early this summer, which said essentially they found it to be safe. The evidence for efficacy was a little mixed, but the study was a small one, and that's not surprising. So they're pressing on with their studies, and other studies have not released results yet, but I think this is a promising area. Other alternatives, could you, once the synuclein's there, could you clear it? Could you make it go away? Could you make the brain resorb it? And there is interest in these kinds of strategies as well. So, this is really attacking the fundamental nature of the disease, and I think that's a very important area. What about LRRK2 inhibitors? A lot said about LRRK2 inhibitors. LRRK2 is the one of the most common genes, as we mentioned, that triggers Parkinson's disease. Now, LRRK2 mutations are not that common. Particularly in our clinic, it seems to be 1 or 2% of the patients we see actually has this, so it directly affects a small number of people. But if you have one of these gene alterations, you have increased activity of LRRK2, and turning that off might be beneficial. And there are early human trials going on at several places looking at this. If it worked, would it be just for people with a LRRK2 mutation, or would it be for everyone? That's a really interesting question. And some work that we've done here with Andy West, our Udall Center collaborator and colleague, suggests that actually LRRK2 inhibitors might be useful for everyone with Parkinson's and not just those with a mutation. That's something we'll have to wait and see. But this is certainly an area that's being studied very actively. And then lastly, anti-inflammatory treatments. This is much of the focus of the Alabama Udall Center. The idea that the immune system is driving the progress of the disease, perhaps triggered by alpha-synuclein. It may be abnormal alpha-synuclein that triggers the immune system to get involved and to become active and to produce damage in the brain. And we've accumulated evidence in animal models that this is true. We have a little bit of evidence from human studies, but really one of the big goals of the Alabama Udall Center is to find out if this is true, understand how the immune system is involved, and get to the question of, if it's the immune system, how can we shut that down? We have immune treatments for many conditions in medicine. We don't have an immune-based treatment for Parkinson's, but maybe we should. And maybe this is the best way to actually slow the progress of the disease. Certainly we have put a lot of our time and energy into this, and Dr. Yakubian will talk a little bit about specifically what we're doing in this area. All right, so with that, I will conclude my part and hand it off to Dr. Amara to talk a little bit about early and prodromal Parkinson's disease. Amy?
Hey, good afternoon, everyone. I am, as Dr. Standard said, going to talk about what some of the early symptoms of Parkinson's disease are. So we can go to the next slide. So as you start experiencing symptoms of Parkinson's, a lot of times the disease has already been going on for several years by the time you start noticing the motor symptoms. And some of the early manifestations and the way that we diagnose Parkinson's disease is, first of all, with slowness of movement, which is called bradykinesia. And if you have that plus either rest tremor and or rigidity or stiffness, then that allows us to meet the clinical diagnostic criteria for Parkinson's. And on the bottom left, you can see this picture. The left panel shows a slice of the brain through the brainstem, and the slice on the top shows a person who does not have Parkinson's disease. And you can see that there's a blackish coloration in the substantia nigra area. And Dr. Standard's using the mouse, thank you. That's the neuromelanin, and this is the normal staining of the dopamine neurons. And in the bottom on that left side is a Parkinson's patient who has lost a lot of that discoloration or that coloration for the neuromelanin. And again, this is something that happens in a progressive manner and has occurred extensively by the time you experience motor symptoms. In the middle panel, we actually look histologically at the brain in the substantia nigra and are actually looking under a microscope at the dopamine neurons. And the top panel shows what would be normal And that bottom is a Parkinson's brain where there's a loss of those dopamine neurons. And then on the right, looking even more closely, is within the dopamine neurons, looking at a Lewy body, which is our pathologic hallmark of Parkinson's. So these are the changes that the brain is going through and ultimately leads to the motor symptoms in Parkinson's. And when we think about how Parkinson's progresses, it is slowly progressive. And a lot of the changes happen before we even notice the symptoms. But on the pictures there of the brains, this is one proposed pathway of progression that was put forward by Brock and colleagues. And this Brock hypothesis proposes that there's a preclinical stage, which we also call prodromal Parkinson's, where the brainstem is affected early, as is the olfactory bulb, and that's the arrow that's pointing toward the front of the brain. And those areas can cause loss of sense of smell and other symptoms, and that can happen before the motor symptoms ever start. And then as the disease progresses, in the middle panel, there's the where the substantia nigra up in the upper part of the brainstem starts to become involved, and people develop the motor symptoms of Parkinson's. So that slow movement, the tremor, and the stiffness. And then as the disease progresses further, there can be some involvement of the cortex or larger parts of the brain, and that can lead to cognitive impairment and other symptoms that become bothersome in the later stages. Okay, the next slide. So when you're around your family members and other people may have noticed signs before you even did when you had early symptoms of Parkinson's. And some of these can be things like a reduction in arm swing. A lot of these symptoms are asymmetric, so you might only have one arm that's not swinging as well, or you might have tremor only in one hand and not the other. You also may have been told by family members that you're stooping over and not walking as efficiently as you did before, with more of a shuffling gait and shorter stride length and things like that. Or people might ask you what you're upset about when you're not feeling upset, and it could be related to a decrease in facial expression. And over time, and sometimes early as well, you can get more quiet speech and more trouble projecting your voice, or actually even a change in handwriting. And if you click one more time, I have an example here of one patient who wrote, "I'm afraid I might fall." And you can see as her handwriting goes across the page that it gets smaller as it moves across. So sometimes the tremor can cause the handwriting to look a little bit tremulous, and then also it can lead to it being smaller over the page. Next slide. So in addition to these motor symptoms that we've talked about, Parkinson's patients often also experience non-motor symptoms. And so these are things like sleep problems, cognitive changes, mood problems, and autonomic dysfunction. So with sleep problems, this can be a multitude of things. It can be insomnia or trouble going to sleep at the beginning of the night. It could be sleep fragmentation or waking up frequently through the night. It can be waking up earlier than you'd like to. You can have daytime sleepiness, even if you feel like you're sleeping well through the night. And then acting out dreams, which is called REM sleep behavior disorder, which I'll talk a little bit about more in a moment. Now this figure here is what's called a hypnogram, and it shows a progression of sleep through the night. So you can see on the left side, it shows wake, and then the non-REM stages in 1, 2, and 3, and REM. And the REM, or dream sleep, is the green shaded panel. And so you can see that there's more of the deep slow wave sleep or non-REM stage 3 sleep at the beginning of the night, and then more of that green part, the REM sleep, as you progress through the night. And you can see that the people tend to stay asleep well when they're sleeping normally. And if you click one more time, we have hypnograms from 2 Parkinson's participants in our research studies, and you can just see how different this is. There's a lot of awakenings, so where the bars come back up toward the top, and there's a reduction in the amount of REM sleep and in the amount of slow wave sleep or non-REM stage 3, and just a lot of trouble falling asleep and staying asleep. And so this can be really disruptive to sleep quality, but as well as to daytime symptoms. And then in early Parkinson's disease, we don't usually think of cognition as being a big problem, but there are some changes that can occur even before diagnosis of Parkinson's. And these can be things like trouble paying attention, and that may be related to sleep. There can be word finding trouble, like the tip of the tongue phenomenon, where you know the word you want to say and just can't get it out. Or planning problems, like trouble getting through a task, and this is called executive dysfunction. And then other non-motor symptoms include mood problems like mild depression or anxiety, or apathy, which is just not caring as much about things that you used to enjoy or used to be very passionate about. And then there's also autonomic dysfunction, and this can be constipation or lightheadedness or getting dizzy when you stand up, or other urinary or sexual symptoms. Next slide, please. So now I'm just going to talk a little bit about prodromal Parkinson's disease. So we mentioned that by the time you develop the motor symptoms of Parkinson's, sometimes the disease has been progressing and making changes in the brain for a long time, sometimes for many years. And so some of the things that can happen and show signals of the earlier prodromal Parkinson's disease are things like REM sleep behavior disorder. And this, I'll talk a little bit more in the next slide, but it has been very significantly associated with later development of Parkinson's disease or other forms of Parkinsonism. And in fact, there's some longitudinal studies or long-term studies following people with REM sleep behavior disorder that shows that they have about an 80% chance of developing some sort of Parkinsonism or cognitive dysfunction over time. Now, another very strong prodromal feature that can be seen as hyposmia, or impaired sense of smell. And many, many Parkinson's patients have experienced this. And this is not as specific as REM sleep behavior disorder, meaning that there are other causes of hyposomnia, hyposmia, than just Parkinson's disease. So other things can cause loss of sense of smell. And this is also true of constipation. Many patients who develop Parkinson's disease will have had constipation for several years. However, Parkinson's disease is certainly not the only cause of constipation. And then, as Dr. Stander talked about, there are many different genetic causes of Parkinson's. And some of these, like LRRK2 and GBA, have a high chance of eventually developing motor symptoms of Parkinson's. And so people who have those genetic features might be considered to be prodromal Parkinson's disease. And then there are a few other things that have also been proposed to possibly be prodromal symptoms, just not quite as specific as the ones on the left side of the page. So excessive daytime sleepiness may start years before Parkinson's develops. There may be some mild depression and possibly anxiety that precedes onset of Parkinson's, or at least the motor Parkinson syndrome. There can be orthostatic hypotension and other autonomic symptoms, and then some mild degree of cognitive impairment, as I mentioned before. So a lot of these things can happen for many years before the symptoms start. Next slide, please. So just to say a little bit more about REM sleep behavior disorder, since it is so associated with Parkinson's, this means there's a loss of the normal paralysis of dream sleep. So normally when we dream, our body is paralyzed. The brain sends a signal to our muscles through our spinal cord to keep us from moving around during sleep so that we don't act out our dreams and hurt ourselves. But if that paralysis is lost, we then can act out our dreams, and this is what is called REM sleep behavior disorder. And as I mentioned, this is very common in Parkinson's. It affects probably approximately about 50% of people. And a lot of times the dreams that are associated with REM sleep behavior disorder are unpleasant and very vivid. And so they can be dreams of someone attacking the patient or their family member. And they also often lead to violent behavior during sleep, like having to fight back against those attackers. And so that leads to risk for the patient and their bed partner, because if they try to punch someone who's attacking them, they might end up punching their bed partner, or they could fall out of bed or leap out of bed even. So what's one interesting thing about REM sleep behavior disorder is that while Parkinson's causes these slow movements and quiet speech, when patients with Parkinson's are acting out their dreams, they tend to move really fast and have their normal speech volume. So it's some sort of different mechanism through which these movements are happening during dreams. And unfortunately, people who have REM sleep behavior disorder and have Parkinson's often have some worse motor and non-motor symptoms. So more risk for memory problems, more risk for hallucinations, and maybe even more risk for falling. And I just put some pictures here that shows what happens during a sleep study. So this is on the top, a 30-second period of time, the way that we look at the sleep study. And the top leads are the brain waves and eye movements. And then where I've labeled there, the chin EMG is the muscle movements of the chin. And during REM sleep, these are flat. There's very little movement. And then below that is the leg EMG, or the leg muscle movement. And that just shows also not very much movement. And then in the REM sleep behavior disorder patient, you can see a lot of movement in the chin as well as in the leg EMG. So there's this loss of REM atonia. Next slide, please. So what do we do to take care of early Parkinson's disease and even to take care of prodromal Parkinson's disease? So these are things that I tell my patients who have REM sleep behavior disorder as well. So very important to get exercise. And as Dr. Standard mentioned, one of the things that we're interested in learning more about through the Udall Center is inflammation and how the immune system could potentially affect Parkinson's. So exercise is a pretty good way of reducing inflammation. And so that may be one mechanism through which it's helpful. But exercise can be done in many different ways. It can be done through physical therapy with a lot of guidance. It can be done through a routine exercise program, going for walks, yoga, exercise in other ways that you enjoy. Or there are Parkinson's disease specific exercise programs like boxing. There are Parkinson's dance programs. A lot of research has been done on Tai Chi and how it can be helpful for Parkinson's. And then we've found ourselves that Parkinson's can help with sleep disorders as well. So most important, it's good to have an exercise program, but you also need to have the type of exercise that you'll enjoy. So we don't know yet what the best exercise is for Parkinson's, although we're trying to find out. But any movement that you can do and that you'll keep doing, so the ones that you enjoy, that's really important to pursue. Other important things for both early and prodromal Parkinson's is to make sure you're eating a healthy diet. Some that have some evidence for good aspects in Parkinson's are the Mediterranean diet, which really focuses on eating more vegetables and fruits and nuts and beans and whole grains, and then also using healthy fats and low-fat proteins. And then there's also the MIND diet, which has aspects of the Mediterranean diet, as well as the hypertension diet. So the Mediterranean Intervention for Neurodegenerative Delay is the name where MIND comes from. And like I said, it's very similar to the Mediterranean diet, but also specifies that you should avoid things like cheeses and butter and red meats and fried food and sweets. So many of these things are intuitive, and you don't have to be, completely cut out everything you enjoy, but having a good overall healthy diet and cheating just occasionally is a good idea. Next slide, please. Dr. Stander also talked about some of the newer medications for Parkinson's, and we also have many older medications for Parkinson's, and when to decide to start those with early Parkinson's is an individual decision that depends on a lot of different factors. So discussing this with your family and your physician is really important. But some things to consider, medications can have side effects. So before you start them, you want to make sure that you're choosing the one that's right for you, and also that it is the time to start medicine. So some Parkinson's medicines can cause nausea or lightheadedness or other symptoms that can be disruptive. However, some people feel like they are ready to start medicines to treat their symptoms. So it may depend on whether you're still working. So if you, for instance, have a job as a dental hygienist and cannot have any tremor in your job, then you may need to start medicines earlier compared to someone else. It also depends on your comfort level. So if the tremor is driving you crazy and you just want it gone, we can try to do that. Sometimes we're not 100% effective with making it gone, but these things that are important for you weighing the side effects and benefits. And then mobility is really important. So if you are reluctant to start medications, but you wait for so long that you are now not able to get up and move around as well, or you're staying on the sofa all the time and not doing that important exercise, then you are sacrificing mobility to avoid side effects. And that can lead to further problems down the line. So if you get to the point where you're not moving because you haven't yet started medications, it might be the time to do so. And then other important factors are participation in research. And different people weigh these different ways, but every aspect of this decision is different from person to person. Next slide, please. So what are some of our challenges in research as well as in deciding when to treat Parkinson's? So as Dr. Standard mentioned too, one of the things that is foremost in our search is to cure Parkinson's disease, and also to find something that might slow disease progression, even if we can't cure it quite yet. So these therapies probably will be most effective if they're started early in disease. However, some of our Parkinson's medicines that we have now, or most of them, can actually mask our ability to monitor disease progression. And so we have a big search for people who are not yet on medicines to do research. And then also their Parkinson's medications may actually alter some of the biomarkers of disease, again, somewhat impairing our ability to monitor progression. And so that again makes the people who are not yet on medicine who have Parkinson's disease a really ideal population to study. Next slide, please. So what are the opportunities related to that? So people who have early Parkinson's disease or prodromal Parkinson's disease, like those with REM sleep behavior disorder, can be ideal research participants for studies of these neuroprotective therapies or biomarkers of Parkinson's progression, and also mechanisms of why Parkinson's causes the symptoms that it causes. And currently there are quite a few studies that are recruiting people with early or prodromal Parkinson's. So as Dr. Standard mentioned, that does include the Udall Center, and we'll learn more about that from Dr. Yacoubian. And then there's also a new version of the Parkinson's Progression Markers Initiative, or PPMI 2.0, which is starting and is recruiting people with genetic underlying Parkinson's who have not yet developed disease, also REM sleep behavior disorder, and early Parkinson's disease not yet on medication. There's an exercise intervention study called SPARKS-3, which is funded by the NIH, NINDS, and is going to use exercise intervention in patients who are recently diagnosed and not yet on medications. So many different opportunities for newly diagnosed patients. And then there are other studies going on that I didn't mention here. So certainly if you know of people who have been recently diagnosed, or if you are such a person, please contact us. It's very important for research, and we would love to talk to you and get you into clinic quickly if we can. Next slide, please. And now I'd like to turn things over to Dr. Yacoubian. So thank you for listening.
And before she starts, just let me remind everyone, if you have a question, please type it into the Q&A box at the bottom of the screen. We're going to take a few minutes and answer as many questions as we can at the end, but we're going to take them from that Q&A box. So please type them in there as you have them. Dr. Yacoubian.
Sorry, I was muted there. Good afternoon, everybody. I am the director of the Alabama Udall Center Clinical Research Corps, which is part of the larger Alabama Udall Center that Dr. Standard briefly mentioned earlier. So this is a large NIH-funded multi-million-dollar grant that started about 1.5 years ago. And the overall center is really focused on understanding the role in inflammation and has a lot of different research projects under this Udall Center umbrella, some of them being investigations that are being done in animals. The focus of my clinical research course to really understand the role of inflammation in human patients with Parkinson's disease. And so I was going to sort of give you a little bit of overview about what we've been doing in this center, in this research core, where we are and where we hope to go with this project. Next slide, please. So as I've mentioned, our overall overarching goal is to really understand the role of inflammation in human Parkinson's disease. Next. And there are several key questions that we hope to answer during the course of this 5-year study. So the first main question is, is there actual evidence for immune activation early in disease? There's a lot of sort of data in the literature suggesting that the immune system is overactive in Parkinson's disease, but whether this is seen early in disease and how much this may be going on is not clearly understood, and we hope to answer this question next. Another key question is, does inflammation change over time? So there's a lot of different parts of the inflammatory system, and we're looking at different aspects of this and trying to see if the inflammatory response that may be present early on in time, does it change as the disease progresses? And next. And then another key question that we hope to answer over the course of this study is, if we do see inflammation early on in disease, can this predict the disease course for a given patient. So if you see certain markers of inflammation, will this predict that this person will do worse in the long run compared to somebody else who may not have that? And so these are some of the key questions that we hope to answer through our study. Next slide. So to answer this, we are recruiting a group of 120 subjects that we're going to follow longitudinally over the course of 5 years. And so we're enrolling patients with newly diagnosed Parkinson's disease. So these are patients who are within 2 years of their diagnosis and prior to being started on medication. And then we'll have age and sex match controls so that we can try to figure out what changes that we might see in inflammation are really a result of the Parkinson's disease. We'll be following patients annually. At the initial visit, we'll have a huge battery of testing that we'll be doing. One is what we call clinical characterization, where the subjects will undergo neurological examination and then different testing of the motor aspects of Parkinson's disease, and then also those non-motor aspects with a key focus on sort of the cognitive features of the disease. Patients at that first visit will undergo blood draws, and then this is not required, but we strongly encourage the participants to also undergo a lumbar puncture so that we can get cerebrospinal fluid. And then these samples will be used for looking at inflammatory markers early on in the disease. Another way that we'll be looking at inflammation is to do a new type of PET imaging, something called DPA 714, also known as TSPO. This is a type of special scan that can look at immune cells in the brain that we're doing. And then these testing will be repeated on an annual basis, where patients will come back on a yearly basis, where we'll repeat the blood testing and then the cognitive and clinical characterizations, though we will not be repeating the scans. The scans are for that first visit. And all of this data that we're collecting is all de-identified and kept in our own databases, but in order to help advance Parkinson's research, we also put this in these NIH-sponsored databases to allow other researchers in the Parkinson's disease field to help us make headway in understanding this disorder. Next slide. So this is just sort of showing where we are in terms of enrollment. As I mentioned before, our goal is to have 60 patients with early Parkinson's disease and 60 controls. We started our first enrollment just before Thanksgiving in 2018, and we've been doing really well. We're more than halfway there in the first 18 months of our study. We have 38 subjects who are newly diagnosed Parkinson's disease, and then 28 controls. Unfortunately, because of COVID, we've had to put our enrollments and our study visits on hold starting in early March, but as we're hoping that over the next few weeks, we'll be able to safely restart our enrollment and continue our study visits, and so that we can reach our goal of 120 subjects. Next slide. This is just sort of a quick summary of some of the data that we've been collecting. So for the 66 participants who've been enrolled, we've obviously done their initial clinical assessment, their neurological testing, their Parkinson's tests, gotten blood samples. A fair number of these subjects have been willing to undergo spinal fluid, and we're going to be continuing to encourage participants in the future to contribute this, because this will be a key aspect of the study. And then most of our patients have had the PET scan or the cognitive battery, though some of these studies had to be put on hold due to the COVID shutdown, but we'll hopefully be able to catch up on that later on this summer. Next slide. So this is just some summary sort of showing, some of the demographic information of the people who've been participating. So we've done a good job overall in sort of matching participants between the control groups and the Parkinson's group with regard to different demographic features. They're relatively well matched in age, generally well matched in gender. As many of you may know, Parkinson's disease is more common in male persons, and so therefore we've been able to more easily enroll male, and so one of the focus for the next year is to really identify more female participants to be able to participate in this study. We're well matched in terms of ethnic and racial groups, education, and employment status. Next slide. So this is just sort of showing some of the medical problems that our participants may also have in terms of sort of common disorders like hypertension, diabetes, heart disease. And we find that the control and the Parkinson's disease groups are well matched. There doesn't appear to be any significant differences in terms of medical history, so that any changes we do see with regard to inflammation is likely due to Parkinson's disease and not due to medical or demographic differences. Next slide. So this is sort of a summary of some of those clinical scales I mentioned, and this is sort of part of the heart of the study is looking at baseline. Are there any differences in some of these assessments between control patients and Parkinson's disease? And then we'll be following this over time to try to see if these scales may differ with regard to the amount of inflammation that we might see in one group versus the other. And so, as expected, our patients who have Parkinson's disease, they show clear differences in sort of the motor assessments for Parkinson's disease. And this is sort of seen in the top in the MDS-UPDRS. The other differences that we see in these patients who are at the very earliest stages of Parkinson's disease, they're not requiring medications. Even at this stage, we do see some mild differences in terms of quality of life measures like the Schwab and England ADL score. These patients do show a clear and significant difference in terms of their smell, ability to smell. And as Dr. Amara mentioned, one of the sort of prodromal features of Parkinson's disease may be this loss of smell, and we clearly see this in our Parkinson's group. Another scale that we've looked at is what we call the SCOPA-AUT. This is a measure of what we call autonomic function. So these are things like controlling constipation, sexual function, sweating, and things like that. And it's thought that these might be earlier features of Parkinson's disease, and our own small group so far shows that there is a difference in autonomic function between our control and Parkinson's disease patients. And then the other thing, other key feature that we're already noticing that is different is something called the MoCA scale. So the MoCA is sort of a quick cognitive screening test that we do. And while the differences between our control and Parkinson's disease is relatively small, only about a 2.5 point difference, this is significantly different, suggesting that even early on in Parkinson's disease, before patients need any medication, there might be some subtle cognitive changes in persons with Parkinson's disease. Next slide. So the MoCA scale is sort of a quick and easy scale that we commonly do even just in a clinic visit, but we want to have a better understanding of some of the cognitive changes that may be occurring early on in Parkinson's disease. So the subjects in the Udall study, after their initial visit, come back a couple of weeks later where they do a more extensive battery of cognitive tests that takes about 90 minutes, where we're testing different aspects of their cognitive function, from attention, visual and verbal memory, visual spatial skills, language, and other aspects of cognitive function. And in our group so far, we don't see any clear-cut or what we term statistically significant differences between controls and Parkinson's disease, but we do see some trends in areas that may not be too surprising. So in our persons with Parkinson's disease, we do see that they may have some changes in their ability to focus as measured by attention. in aspects of verbal memory and also in processing speed. And these are sort of areas of a cognitive function that have been described, at least in later stages of Parkinson's disease, to be areas that persons with Parkinson's disease have. And so what will be interesting to see, so far we don't have the data yet in terms of how much inflammation is happening in these patients. That the samples from the blood and the spinal fluid has been collected, and while some of the tests have been done, we're still blinded until we enroll all of the patient. But what will be interesting to see is if some of these measures of cognition may correlate with any inflammatory changes that we see in the blood and spinal fluid. So that will be something that we'll hopefully know over the next few years as we finish enrollment in this study. Next slide. So the last thing I sort of wanted to mention before we go into the Q&A session is to talk briefly about the TSPO PET. So this is sort of a newer technology for PET that allows us to look at inflammation in the brain. That doesn't involve, any major intervention like a spinal fluid or something like that, which is a little bit more invasive than a scan. And so TSPO is a molecule that is found in immune cells that can be found in the brain called microglia and monocytes. And there have been radiochemists who have made these, what we term radioligands, that can sort of be given through an injection, go up into the brain, and then label these immune cells in the brain, so that then with the PET scan, we can take pictures of this to sort of see if there's evidence of these immune cells up in the brain. So there's been different radioligands that have been created over the years, and the radioligand that's one of the newer ones that's now available is called DPA-714. This was originally produced in Europe, and then we here at UAB are now the first site in North America to use this ligand, and this is the ligand that we're using to image inflammation in these Udall subjects. So next slide. So this is just sort of some pictures showing the scans in some of our subjects with Parkinson's disease. So this was a pilot study that we did prior to starting the Udall project, and to just show that we can get this technology to work here at UAB. And so these subjects were given the dye, and then at a certain time point after the dye is injected, pictures with using the PET scanner were taken to sort of detect the dye up in the brain. And so up at the top, sort of in the middle, that is sort of shows one of these subjects who with Parkinson's disease, and as you can see that there's a lot of sort of light blue greenish sort of signal, and this is sort of the radioligand showing that there is some amount of inflammation up in the brain. Now if we look at the image just below that, so you can see that this is quite dark. It's mostly purple, suggesting that there's very little sort of binding of this radioligand. And this was a control subject that we used. So this is a person who has Parkinson's disease, but they have a genetic change that doesn't allow them to bind this radioligand. And so this showed to us that the dye that we're giving is actually lighting up specifically in the brain. And then we've, since that time, imaged several more subjects like the two below that show that at least in Parkinson's disease, there does seem to be some amount of inflammatory changes in the brains of these subjects. And what we'll be doing with the Udall study, we have, I think, about 45 of our subjects who've been imaged. We'll be comparing those who are control participants versus those who have Parkinson's disease to see if there are any consistent differences in specific brain areas with regard to this inflammatory measure. Next slide. Next, okay. So what I wanted to mention here is how can you help with our study? So as I've mentioned, our goal is to recruit 120 participants in total, and we're just a little bit past halfway there. You know, and we don't need just persons with Parkinson's disease, but a critical aspect for us to answer these questions about inflammation and Parkinson's disease is also the enrollment of healthy controls. So people who are otherwise healthy and are not on any, don't have a history of any inflammatory immune disorders are ideal subjects for us to help us understand the role of inflammation in Parkinson's disease. We still also need people with Parkinson's disease. These are people who are relatively newly diagnosed within 2 years of diagnosis and have not started on medications. We don't want our results to be clouded by the impact that Parkinson's medications may have on the immune system, and that's why we've limited this study to early on in disease. And in particular, we need females who are newly diagnosed with Parkinson's disease. So please reach out to family, friends, colleagues, or yourself who want to really help us develop better therapies for Parkinson's disease. I've listed Lauren Ruffridge. She's the study coordinator who helps with the enrollment and getting patients scheduled and coming to their various visits. And I've listed a number below that you can reach her at if you have interest or have any family or friends who would be interested in helping us out with that study. Next slide. And so I will end there. The Udall team is a huge team. This is really only a fraction probably of all the different people across UAB that are involved in this study. But you know, it takes a lot of us to really be able to examine these really important and challenging questions. And if we do find a clear role for inflammation in Parkinson's disease, this will lead us to a whole new area of treatment options for our patients. Next slide. Okay, and then I will end there.
All right. Well, thank you, Dr. Yakubian. That was fantastic. So we're going to go ahead and take a few questions here. Katie Fugler, who's our Director of Development and Community Relations, is going to try to organize those for us. So what kind of questions do we have, Katie?
So they've kind of gone in order of you guys presenting. So I think some of these first ones are probably for you, Dr. Sandert. Up first, what are new medicines on the market? And then what success does Inbrija have for Parkinson's?
Well, I listed 5 new medicines on the market there, and those are all within the last year and a half. So I think we could spend a lot of time on it. To touch on Inbrija, so Inbrija has levodopa is the active ingredient, and this is the old standby in Parkinson's. It's been around since 1969. That particular treatment is a way of getting levodopa into the lungs rather than trying to swallow it as a pill. The idea is that it will work much faster and is useful for people who have episodes where their medicines wear off and they need a quick start to get going again. So, you know, I think it's been on the market probably a year or so, and certainly we've used it. The levodopa is effective. It's one of several different ways to treat that wearing off. And, you know, like so many things with Parkinson's medicines, you really need to sit down with your doctor and talk through the different alternatives. What's best for one person is not best for someone else, and it's a very individualized experience. But it certainly is one of the effective medicines you can use for wearing off.
We're short on time, so I'm going to kind of run through these. What are some examples of wearing off symptoms?
So the typical experience of wearing off, most people when they first start medications, and usually you experience wearing off if you've been on levodopa or Sinemet. Most people in the early years, the first few years, they take the medicine and it works all day and maybe all night, and they don't really notice any change during the day. But after several years, they'll find the pills don't last as long. They wear off at the end of the dose. They start to feel they need more medicine. They have more tremor, more stiffness, more slowness, sometimes other symptoms. About half of patients will have wearing off at 5 years of treatment. So that's about where we really begin to see it. So there are different ways to deal with it. You can, if you're taking Sinemet 3 times a day, you could take it 4 times a day. Then you could, if that doesn't work, there are a variety of other ways to address this. Inhaled levodopa is one. COMT inhibitors are another. The new sublingual apomorphine is another. The list has actually gotten longer, and I think it's really pointed to the fact that it helps to have some expert input when you try to sort out what's the best approach for you.
Okay. My family member was diagnosed with early onset 20 years ago when he was in his early 30s. What is the relationship of age to Parkinson's?
The older you get, the more likely you are to develop Parkinson's. That's really pretty straightforward. So at age 30, it's quite a rare disease. Now, Michael J. Fox developed Parkinson's when he was 31, and there are certainly patients. I think the youngest we've seen in Alabama was as young as 14, but certainly there are patients that develop it quite early, but the average age of onset is about 63. And the older you get, the more likely it becomes. So it's a rare thing to develop in the 30s, and oftentimes there's a very strong genetic influence in people who develop Parkinson's that young.
Seems like so much attention on newly diagnosed and those not taking medicine. What is new for those of us 4 to 5 years past diagnosis?
A lot. I think probably we should have the PAA invite us back, and we'll do another session on advanced Parkinson's, because that's a whole topic of its own. Very important, but just can't do it in an hour.
And honestly, I think we probably need to stop. And I've got these questions, and we can follow up kind of offline.
All right. So we've used up our hour here. So thank you all for joining us. And sorry we didn't get to all the questions, but Katie can get back to you with individual answers if you want to reach out to her. And thank you for spending part of your afternoon with us, and have a great weekend.